It's a pleasure to be here. I'm not an expert in glycobiology. I'm not a neonatologist. My expertise is in pediatric immunology, and I would like to share some of the more recent work we have done to elucidate genetics of the human immune system. So this little sculpture is a little child in front of the main door of our hospital, and it reminds us actually every single morning what we're supposed to do. In fact, for many children diseases, we even today have not a good understanding what causes disease and how to treat diseases. So even today, more than 1,000 years then later, when Avicenna said we should know more in medicine, we should know more about the causes of sickness and health, I think we have to be modest even today because our knowledge is still quite limited. So rare diseases, I think, as you all know here in this audience, offer tremendous opportunities to learn about basic principles of health and disease. And I think this is now a very fantastic and wonderful era. Over the last decades, we have made great progress in biomedicine and biology, in principle, by looking at model organisms of developmental biologists, from frogs to mice. And many of these tremendously important discoveries made in these organisms were honored by the Nobel Prize. I think nowadays we can use the same principles and use the most relevant species on Earth, Homo sapiens, and study many of these pathways that are important in controlling growth and function of organs in children with rare diseases. And this is Nelson's textbook of pediatrics, and of course pediatrics is a discipline that has widely distinct subspecialties, but all of these subspecialties give us now the opportunity to study basic factors that are important to maintain health in children. And if we do so, we can widen our perspective and we can work together across countries all over the globe and look at rare phenotypes and figure out what's wrong with them on a genetic basis. And this is what we do. And one of our interests is a disease that is characterized by recurrent severe bacterial infections due to a lack of neutrophil granulocytes. The disease is called severe congenital neutropenia, and as a consequence of this paucity of neutrophils, children develop recurrent bacterial infections, of course. The phenotypic association is schematically shown here. So this is the maturation of myeloid cells from myeloblasts to mature neutrophils. And in this particular disease, severe congenital neutropenia, there is a block of maturation right here. So we do see promyelocytes in the bone marrow, but almost none of these more mature forms. So we do work together with a worldwide net of clinical collaborators spanning many countries and continents to actually look out for these rare phenotypes. And now there is a link to glucose and sugar metabolism here. This is one disease that we came across a few years ago in a pedigree that was not German. That was an Aramaic pedigree, so from the Middle East. And these particular children in this index families suffered from a problem of neutrophil granulocytes. So this is a bone marrow smear. You do not see any mature neutrophils, but you only see promyelocytes and earlier cells. And this is very suggestive of this phenotype of severe congenital neutropenia. In addition, those patients had other features. Some of them had an atrial septal defect type 2. Like in many other children with severe congenital neutropenia, neutrophils are characterized by an increased susceptibility to undergo apoptosis. This was also true in this particular pedigree. We had an increased apoptosis in response to TNF-alpha in patients in comparison to healthy controls. And we eventually came up with a causative mutation in this pedigree. We found a biallelic homozygous mutation here in this gene called G6PC3, which is glucose-6-phosphatase catalytic subunit 3. You may know G6PC1, which is the traditional conventional glucose-6-phosphatase, and like G6PC1, G6PC3 is able to mediate dephosphorylation of glucose-6-phosphate into glucose-3 phosphate, which could be mirrored and modeled in a yeast system. When we express G6PC3 wild type, we were able to actually measure enzymatic activity, which was completely abrogated in this mutated form of G6PC3. Now, G6PC3 has not been linked to human disease before. However, the homologue G6PC1 is a well-known player. If you lack G6PC1, you suffer from glycogen storage disease type 1, which is characterized by glycogen storage, of course, hypoglycemia and metabolic problem, but no immune disorders associated with that disease. There is another variant of glucose of glycogen storage disease type 1b, which is caused by mutations in a gene that encodes the glucose-6-phosphate transporter protein, which mediates transport of glucose-6-phosphate from the cytosol to the lumen of the endoplasmic reticulum. Interestingly, mutations in this particular gene cause not just the phenotype of glycogen storage, but also neutropenia. It was completely unknown how that would work until we discovered these mutations in G6PC3, also associating with this transporter. And here we have now a ubiquitously expressed gene versus a gene that's expressed in liver, kidney, and intestine. This one regulates glucose metabolism. This one appears to regulate a more fundamental homeostasis in the endoplasmic reticulum. Endoplasmic reticulum is very sensitive to stress responses. There are three canonical pathways that sense ER stress and then cause cellular responses. And in the cells and in the myeloid cells of these patients, you see already on a phenotypic look here, an ultra electron micrographs here, you see this, that the endoplasmic reticulum is ballooned and very blown up in comparison to a healthy ER, and also biochemical markers of BIP expression are severely upregulated, suggestive that these patients actually have an increased ER stress response. Now, in addition to congenital neutropenia, which is a very common, which is a decisive feature of this disease, there are various other issues ranging from cardiac malformations, atrial septal defect type 2, or one patient with a triatrial heart, pulmonary stenosis, undefined myopathy. 2 patients had inner ear hearing loss. Urogenital malformations were pretty common, in particular in boys. And then there is this very striking feature which makes the diagnosis pretty easy, increased venous marking. Almost all of these patients have this visibility of veins, probably due to decreased subcutaneous fat. Now, more recently, when we acquired more patients, there were some additional features. We are not quite sure whether those are part of the syndrome or just randomly associated. There were like 2 or 3 patients with mid-phase hypoplasia here. Inverted nipples were found in a few. And cutis laxa also was identified in a few patients. So by now, there are about over 20 various mutations identified in this disease, and we know about maybe 50 patients in the world. In collaboration with Andel in London, it was made obvious that this disease affects the glycosylation pattern, our neutrophil granulocytes. The pattern of the glycome in neutrophils is clearly striking in these patients, and now I think we think, well, some people argue that this could be a subform of congenital glycosylation disorders, but this, of course, is a matter of debate. Interestingly enough, we have now a few other patients with congenital neutropenia and we subjected their cells to a mass spec analysis in An's lab, and we found similar patterns of aberrations of the sugar coating here in neutrophils. So this could be a general theme, but we're not quite sure about this yet. Now, looking at a large cohort of patients with severe congenital neutropenia or congenital neutropenia, like more than 200 patients, there is a fraction, about 50%, we actually can identify now, and we can categorize based on genetic mutations, but there is a larger fraction that still requires further investigations. Now I have another two chapters briefly to talk about the power of genome medicine maybe. My second chapter is about this little girl who unfortunately died because we were not fast enough to identify her defects. If we had known this earlier, I'm sure she would still be alive. She was born to a consanguineous marriage from Lebanon. She had two affected siblings, and when I met her, both of the siblings already had died of liver disease. So the disorder was characterized by severe liver failure. You see a huge liver here, and you see an associated cholangiopathy. So the bile ducts are enlarged, and this causes severe cholangitis and consecutive liver failure. The family was taken care of by the team of pediatric hepatologists and gastroenterologists, and eventually they came across and asked us whether we could help. In fact, this is a path analysis of one of her brothers who died previously. You see severe hepatic fibrosis in this family. My first inclination for differential diagnosis was to look at the immune system. This is because I'm an immunologist, so you focus on what you know. In fact, the T cell parameters were pretty non-striking. T cells were there, they differentiated normally, and they were able to proliferate in response to anti-CD3 signaling. And also the other mitogens were able to induce proliferation of T cells. The B cell investigations were not so abnormal, with the exception of an IgG that was borderline low, but not really striking here. IgE was high, but that's seen very often. And the subtypes, debatable. It is true that the IgG3 level was low, but in fact there are many normal healthy patients with variations in their immunoglobulin subtypes as well. So in fact, here we had a disease that was not clearly attributable to an immune phenotype, but we were suspicious and we didn't give up prematurely. And we went back into aggressive investigations until we eventually identified something that was not previously documented before. We found these little organisms in the liver and in the duodenum. These are Cryptosporidia. And there is... if you have Cryptosporidia in your bile duct, you have an immunodeficiency. It's pretty common in HIV. It's pretty common in various T cell deficiencies. So here we had a hint that in fact this disease was a T cell deficiency disease. A bit more detailed immune assessment looking at T cell proliferation in response to specific antigens actually did reveal that there was a problem, and there was also a decrease in class which B cells, substantiating the idea that there is some sort of combined immunodeficiency as the underlying diagnosis. Here in this pedigree we went on and did perform exome sequencing. We were able to retrieve tissue on one of the deceased brothers, so we had two affected siblings and a consanguineous parent. We sequenced one healthy brother and the two affected, and we came out with two variants that were potentially disease-causing, RAB3, IL-1, and a mutation in the interleukin-21 receptor. So this particular variant did not segregate within all family members, whereas the IL-21 receptor did segregate with the disease phenotype in all family members. So the mutation is a mutation in at position 201, causing an amino acid exchange from arginine to leucine. This particular region of the protein is highly conserved. And once we modeled the mutation based on recently made available structure analysis of the interleukin-21 receptor, you can see that this does cause a trichromatic change here and very likely abrogates the function of this receptor. So the interleukin-21 receptor is part of the IL-2 receptor family. If you lack interleukin-2 receptor, you have severe combined immunodeficiency. So now we actually add, the same is true for IL-7 receptor. Those are known IL-2 receptor family deficiencies. Now we have to add IL-21 receptor to this list. So a set of experiments we initiated was to prove that this mutation actually abrogates function. So the interleukin-21 binds to this dimer of the gamma chain and the IL-21 receptor alpha chain. It mediates signal transduction via JAK1, JAK3 to STAT3, STAT1, and STAT5. So we incubated cells of the patient with recombinant IL-21 or IL-10 as a control. And you can clearly see that the patient is severely affected in her ability to respond to recombinant IL-21 with respect to phosphorylation of STAT1, STAT3, and STAT5. Whereas the receptor as such is expressed. So this mutation does not cause protein deficiency. IL-21 has pleiotropic effects on multiple cells of the immune system. So on T cells, Th17 cells, NKT cells, NK cells, B cells, and myeloid cells. And those cells in green actually produce IL-21. So it's a pretty complicated scheme. To measure the consequences of deficient IL-21 receptor signaling in patients, we looked at this also in a functional experiment. We set up an in vitro system looking at immunoglobulin class switching in response to CD40 ligand and IL-21, IL-4 and TGF-beta as well. And as you can see here, the patient has a severe problem in inducing IL-21-mediated class switch in B cells. So this is another example of a primary immunodeficiency disease. Over the last few years, we have had the chance to work on several of those disorders. And IL-21 receptor is the most recent asset to this growing list. And I'm not quite sure whether I follow the hypothesis or the statement earlier today that the list of monogenetic diseases is limited to, I don't know, what did you say, 3,000 unknowns? I could imagine that this list is even much larger. But because if just a single laboratory discovers so many novel genetic defects, I think we have a lot of work to do here across the world. And in an attempt to bring patients from underprivileged countries to medical care, like in Europe or in the US, I was involved in the creation of this new foundation, Care for Rare Foundation, because we have had this experience that sometimes it's so difficult for patients from Iran or India or Pakistan to really get access. So we're trying to raise some money in Germany and Europe now to help those colleagues in less privileged areas. And the foundation has been critical now to sponsor certain medical centers, pediatric academic hospitals in various other countries to help to bring together those patients with rare diseases so we can make some progress faster than in the past. And in the last part of my talk, I would like to comment on our experiences in a gene therapy trial for another rare disease. This is a primary immunodeficiency disorder called Wiskott-Aldrich syndrome, a rare immune disorder characterized by bleeding due to thrombocytopenia, autoimmunity, vasculitis, eczema, recurrent infections, of course, and also is a predisposition to the development of leukemia and lymphoma. The general life expectancy of these children is very much reduced to 10 to 15 years unless those kids are treated by allogeneic stem cell transplantation, an approach that even today remains risky, in particular if there's no HLA-matched donor available. So about 12 years ago or so, we have started to develop a new therapy based on the genetic replacement in hematopoietic stem cells from these patients. So the principle is quite simple. We take stem cells from these kids, purify CD34 cells, transduce these stem cells with retroviruses encoding a healthy copy of the WASP gene. The patients are being conditioned with busulfan, which is needed to make some space in the bone marrow. This is not completely myeloablative, but partially myeloablative, and then we reinfuse these corrected stem cells. Here's our vector system, which is still based on a first-generation retroviral vector, which is, of course, done in highly specialized laboratories. And we have treated, using this approach, 10 patients. The youngest was 3 years, the oldest was 14 years at the time of therapy, a wide range of various mutations. And you can see here that for the most part, those patients received a pretty high number of hematopoietic stem cells, like 10 to 20 million. There was one patient in whom we were unable to acquire enough stem cells. This particular guy, he had a very high dose, long-term steroid therapy, so probably he has lost most of his hematopoietic niches. We're able to give him therapy only with like 2 million per kilogram. This was clearly not enough. This attempt failed. He continued to be pretty sick. We watched him for some time and then did a haplotransplant, which fortunately worked quite well. All the other ones were available for long-term follow-up, which is putting together the results of this trial. We treated the first patients in 2006 and then followed them for up to almost 6 years. You can see here that in basically all principal and important immune cells, there is high-level correction based on the measurement of WASP expression in peripheral blood cells. This is true for CD4 T cells, for CD8 T cells. The vast majority is positive. B cells, also NK cells equally, less so myeloid cells, such as monocytes, which was not unexpected because we knew from previous animal experiments that there is a survival advantage if you re-express WASP in cells of the lymphoid lineages, but not so much in the monocyte lineage. And the platelets are also almost all corrected. Just a brief glimpse into the functional reconstitution, which was, of course, measured very systematically multiple times. And this is an example of a reconstitution of a deficiency of these dendritic cells of these patients that are unable to form these actin polymers, these little dot structures. Actin polymers can be reconstituted, though, after gene therapy, as can be seen here. And another striking phenotype of WASP-deficient T cells is their inability to respond to mitogens, such as PHA and CD3. So the growth of T cells is perturbed, but upon gene therapy, this is very nicely corrected. Now, clinically, all these patients had a marked benefit, except this one little guy who didn't get enough stem cells. So all of these patients lost their tendency to bleed. They had normalization of their platelet counts. Almost all of these patients completely had a complete resolution of their autoimmune features, such as vasculitis or colitis. This is one example of colitis pre-gene therapy, and post-gene therapy there was no issue anymore. And they lost their predisposition to severe infections. Eczema, another example, pretty severe, and this little boy completely resolved and never came back. On the other side, hematopoietic stem cell gene therapy is not without risks. That is something we know and we knew from Alain Fischer's experience and Adrian Thresher's experience in babies and children with severe combined immunodeficiency. So if you modify your hematopoietic stem cells with the currently available tools, lentiviruses or retroviral vectors, there is an intrinsic risk of a leukemic transformation. In the London-Paris trial, 5 out of 20 patients went on to develop acute lymphoblastic leukemia, clearly associated with gene therapy. And this is why we monitored very closely our patients as well. What we can do now, we can identify all the signatures of these retroviral integrations in the human genome. And this allows us to have, of course, a signature of the hemotabolic system. And over time, there is in this heat map, you can see that certain clones, they pop up and then they disappear again. So this is probably physiological. Hematopoiesis is not a constant thing. There's also always a few clones that come up and generate blood cells, and then they get silent again. And once we look at all patients, all 10 patients in this trial, the follow-up on number 3 was very short, so this is not really comparable. But on all the others, we see actually more than 70,000 integration sites, sometimes recurring, sometimes new. And for the most part, they don't do harm. We do not see any findings on the blood system, so there is no anemia, no thrombocytopenia, there is no anemia. There is no cytogenetic aberration in these patients. We do bone marrows every 3 months. We do not see any fundamental changes. But we had, out of this series of 10 patients, 3 patients, which out of the sudden, without any announcement, so to say, had this severe complication that was seen in the Paris trial as well. This is patient number 1, 6, and 8, who after like 1,800 days or 400 days or 700 days after gene therapy, suddenly came to us with a short history of fever, malaise, and it was pretty obvious very soon in the blood, in the bone marrow. They had blasts that were acute lymphoblasts with an immune phenotype very characteristic of T-cell acute lymphoblastic leukemia. All 3 patients had, at the time of leukemia, but not before, evidence of cytogenetic alterations involving chromosome 7, 9 here, and this is 814. This involves the c-MYC locus, and this is, again, chromosome 14 and 20 here. And at the time of leukemia, but not before, they had a very high contribution of a clone that had a retroviral insertion very close upstream of the LMO2 locus. Exactly the same location that was found in the other patients treated in Paris and in London. Now, it's important to realize that almost all patients, actually all patients that receive hematopoietic stem cell gene therapy have a retroviral insertion at the LMO2 site, but these clones do not contribute primarily to the hematopoietic system. And we need an unknown number of additional events, mutagenic events, to make these clones malignant, and eventually they would actually grow up and cause disease. Now, all of these patients then went on to be induced with conventional chemotherapy, according to our German ALL trial. They all responded. They all are in complete remission and actually following continuous chemotherapy, which is going on for 2 years. Okay, here I would like to stop. This is our hospital in Munich, and I'm very grateful to a great group that is very active in all these investigations. I acknowledge contribution of multiple friends and collaborators all over the world, too many to name them all here. This is a great team of doctors at the Dr. von Hauner Children's Hospital. This is the founder of our hospital, who just turned 200 years 3 weeks ago. And I'm grateful to my patients, because these are all patients with rare diseases, without whom and without the help of their families, we would not have been able to do all these studies. I think we all share this gratitude. Some of these patients have novel diseases, which we identified, some of whom we could help, and some of whom we could not help. This little girl died, for example, because we were too late. If we had known that she had this IL-21 receptor deficiency before she had this severe cholangitis and liver failure, we would have done a bone marrow transplant. It would have been able to save her life. So with that, I stop here and thank you for your attention.
We have time just one or two questions.
Well, you said you were too late, but you know, I'm wondering why did you pick it up at all? I mean, I would have given up if I would have seen, you know, you have a normal T cell response to the stimulation. You have basically normal immunoglobulins, which is minor areas, but still you pursued and found the immunodeficiency. Why? What was the reason for it?
Because I was convinced that I was convinced that there must be something wrong in the T cells because cholangitis. Once we identified the Cryptosporidia, I was 100% sure there must be a T cell problem.